channel.
Welcome back. I hope you filled up with fluids because we have much more for you. I will show you now how you can assess the volume status from a simple transthoracic echocardiography. And as you will see, I will relate to many of the things that you said. The first thing that we will be looking for is we'll be looking for the small ventricle, very similar to transesophageal echo. We'll be looking for the hyperdynamic state, and then we have some features that you might not be looking so much in your echo, but which are very important to us. For example, what I call the intraventricular flow acceleration and the small IVC. Again, something that you do the same with transesophageal echo. Here's a typical example. This is an elderly patient who was hypovolemic basically because he was under very high doses of diuretics for a reason I honestly do not know. So what we have is the small ventricle here, the hypercontractility. You see the myocardium is actually touching each other. We have a turbulent flow with color Doppler. Those are the high velocity flow right in the ventricle here. If we put a continuous wave Doppler through this flow acceleration, we see the typical pattern of a late systolic peaking flow acceleration. Now the velocity is usually not very high and it's not hemodynamically significant, so there's no real obstruction because it occurs very late in systole. And here is another patient. You can see again the same features of a hyperdynamic left ventricle with flow acceleration, only this time we also have a flow acceleration in the so-called left ventricular outflow tract. You can see that here. And the reason we see this is because sometimes we have an additional sign which we call the SAM, or systolic anterior motion. Here is such an example. You see that during hypercontractility, and especially in situations where the LVOT is very small, the anterior leaflet of the mitral valve is dragged or pushed or pulled towards the septum and therefore obstructs the LVOT and therefore causes flow acceleration here. This is what we call secondary SAM because this phenomenon is more prominent in hypertrophic cardiomyopathy, as you will see or you actually saw already in a previous lecture. So this is the SAM, which is an additional sign that the patient could have hypovolemia. One can see the SAM phenomenon not only with transthoracic echo, but also with TE. Bruno, can you comment on this?
Yeah, this is another SAM phenomenon in a patient before myectomy, and you can see the movement of the anterior listel of the mitral valve. And in these other patients with an LVOT obstruction, we can see the same SAM phenomenon. The left ventricle is almost empty, and you see a lot of turbulences with color Doppler.
Yeah. So this is always a very good view to look at the apical long axis view also from a transesophageal approach. And see what happened if we put continuous wave Doppler into the region of turbulent flow. We have high velocities there, so we get actually a gradient. We can even quantify this gradient. And finally, these are the images after myectomy.
And we see that we have the problem is solved. We don't have any SAM anymore. We have a little bit of aortic insufficiency too, but it's not too much.
So what are the predisposing factors for getting such a SAM phenomena? First of all, if you have patients who have left ventricular hypertrophy, especially if they have a special shape of interventricular septum, which we call sigmoid septum, where the basal part of the interventricular septum, where the mitral valve is very, very thick. And some patients have a very narrow LVOT, and that is also a predisposing factor. But I want to ask Bruno a very important question. Why is it important to know if a SAM phenomena is present?
Yeah, for the anesthesiologists that work in cardiac surgery, this is very important because in this moment that you know that you have a SAM, you don't have to give catecholamines, but you have to give fluids.
Very important because the more catecholamines you give, the higher the contractility is and the more obstruction you get. So you can actually drive these patients into even more and more hypovolemia, and you could actually kill these patients. I've almost seen that happen. So very important thing to consider. Bruno showed you previously how to get the IVC from a transesophageal approach. I will now do the same for a transthoracic approach. in the lectures on imaging, we already showed you how to image the inferior vena cava from a subcostal view. I would like to review this and add a few more tricks, because we will need to image the inferior vena cava if you want to assess fluid status and pressure of the right atrium. Now, we have the patient lying on his back, and we put the transducer subphoidal, in other words, underneath the sternum, and then we use a lot of ultrasound gel, and we simply advance the ultrasound probe towards the left shoulder. And at the same time, we let the patient inhale. Okay? And then we will see the four-chamber view, the subcostal four-chamber view. Now remember, the inferior and superior vena cava is located more to the right of the body. That's why we also have to turn the transducer more to the right, and at the same time rotate the transducer so we get in a longitudinal axis. And thereby you will then find a view right here where you would see the inferior vena cava. Now the orientation of my probe is in a longitudinal direction, and that's also the direction that the inferior vena cava obviously runs. What do you have here? This is the inferior vena cava. Here you see a very prominent Eustachian valve, and we can easily measure the inferior vena cava, and I would do that just slightly below it enters the heart, below the pericardium. In this case, we have 15 millimeters. And if we now want to figure out how it responds to respiration, the maneuver that I would recommend is I would let the patient sniff. So can you do this? Yes. And you see while he sniffs, we have a complete collapse of the inferior cava. What does that mean? It simply means that his pressure and the volume status is not abnormal. In other words, we have low right atrial pressures and probably a normal volume status. The vena cava is visible, but it responds to respiration. This is very important. The motion you perform to get this view is very similar to the motion you apply to a screwdriver. See what happens to the anatomic image if I rotate into the inferior vena cava. Now, moving to the right, tilting, and all of a sudden, here we have the inferior vena cava, right here, entering the right atrium. So we're now parallel to the inferior and superior vena cava. That's how you get it. It's very simple. So let me show you some examples. Here is an IVC which is not even visible. It's completely collapsed. It should be somewhere right here. Here is a patient with a very wide IVC, and it doesn't collapse at all. This IVC probably collapses more than 50%. A normal-sized IVC, which collapses less than 50%, I would say. And here, again, a normal-sized IVC, which almost completely collapses. Here are different variations. You can also use the M-mode to look at the motion or the collapse of the IVC. However, that is sometimes very difficult because, remember, when you let the patients inhale, the IVC and the diaphragm moves. And so you will sometimes have to kind of follow the IVC while the patient breathes. So that can be a little bit of a problem. And this is something that Bruno taught me. There's another view that you can use.
Yeah, there is a second possibility to get the IVC in our transthoracic examination. And it's exactly along the right mid-axillary line. You have to put the probe here on the liver high, and then we look for the biggest vessel that we can see.
But you have to watch out not to get the aorta, right?
Exactly. So I would suggest to follow the vessel till we can see the right atria. Then we are sure that we are in the right vessel.
Now let's look at the opposite, not a hypovolemic, but a hypervolemic ventricles. How can we assess volume status in these? Well, we can do the same as Bruno mentioned with transesophageal echo. We can look at the size of the ventricle, but it's very unreliable, as we already mentioned. Here is a beautiful example of a patient who has poor left ventricular function, but who still has a normal volume status. And a patient here on the left has poor left ventricular function and a very large ventricle, but he responds very nicely if you exercise him. So the size of the ventricle changes very much during exercise. So the size, I would say, is a very unreliable factor to look at. I would look more at the filling pressures. The filling pressures are basically the pressures that you have in the left atrium that fill the left ventricle at diastole. And if we look at these curves here on the red, we see the pressure curve of the left ventricle right here, while the blue curve would correspond to the left atrial pressure. And during diastole, we have certain phases where the left atrial pressure exceeds the left ventricular pressure. And that is the time point when the left ventricle is actually filled. And here we would have an early diastole, the passive filling, and this would be the active filling. Now, if we have a patient who has a very high left atrial filling pressure, we would have a very high gradient. And that usually occurs if this left atrial filling pressure is very high. So we can look at the magnitude of early diastolic filling and relate that to filling pressures. And that's exactly what I would recommend to do. The normal spectrum looks something like this, where you have an E wave and an A wave, with the E wave taller than the A wave. If we have a patient who has a so-called restrictive filling, where we have elevated filling pressures, then this E wave will get very, very tall compared to the A wave. The value would be double as high as the A wave. And this would indicate elevated filling pressures. Again, let's compare the normal filling here to the restrictive filling. This is indicative of elevated filling pressures and, I would say, high volume status. To look at the echo tracings, again, this would be E wave, this is the A wave. The relationship is completely normal. The E wave is a little bit higher than the A wave. And here on the right-hand side, we have the classic restrictive filling pattern with a very high E wave and an A wave, which is less than half that of the E wave. So this is what you can use to assess left ventricular filling pressures semi-quantitatively. But we have another way of looking at it if we actually measure the so-called deceleration time. What is the deceleration time? To understand, I need to go back to this slide once again, and we need to look at the curve. In patients who have very high filling pressures, we would have a very steep curve. Here, the descending part of this E wave would be very steep. Compare this to this, right? And so the shorter this deceleration time is, the higher the filling pressures are. And there's a semi-quantitative way of looking at it. You look at the time, and if it's, I would say, less than 150 milliseconds, that would indicate elevated filling pressures and therefore an increase in volume in the left atrium and pressure in the left atrium. Here's the example of this patient I showed you previously. 105 would be the deceleration time. This patient would benefit from diuretics, actually. So to summarize, with transthoracic echocardiography, we have a number of different things we can look at. If you want to look at the volume status, we can look at the IVC, but we can also look at the diastolic filling. A complicated chapter indeed, but I think now it's time that we fill up our fluids, Bruno, right?
Yeah, Thomas, please.
Yeah, I think you need some in your glass.
Thank you very much.